Hey guys, I'm Tania Sundry and I'm an equine veterinarian from Western Australia. Today we're going to cover pituitary pars intermedia dysfunction, but we're going to specifically focus on the new diagnostics and treatments that are available for veterinarians in Australia. PPID is one of the more common age-related endocrine disorders that affects older horses. Studies have estimated that approximately 1/3 of horses over the age of 15 years are affected by PPID, and the range of clinical signs can vary. One of the more common signs of PPID that we recognise and most owners recognise is hypertrichosis. And this is this long curly coat that fails to shed over the late spring and summer. One thing that it's important to educate owners about though is that just because their horse has a normal coat doesn't mean that it won't have PPID. Hypertrichosis doesn't affect all horses with PPID and tends to be considered a bit more of an advanced clinical sign. Some of the signs that are less commonly recognised by owners are things like laminitis, recurrent infections, and this is where the horse or pony might suffer from recurrent bouts of sinus infections, foot abscesses that don't seem to go away, corneal ulcers that take a lot longer to heal, or even wounds in the distal limbs that don't heal quite within the time frame that you'd expect. These animals might also have things like muscle wastage, which generally occurs over their top line. So we just briefly covered the pathophysiology of PPID. You can see that this disease is really characterised by the degeneration of dopaminergic neurons, leading to excessive production of hormones by the pituitary gland. So in a normal situation, activity of the equine pars intermedia has been shown to be inhibited by dopamine and stimulated by thyrotropin-releasing hormone, or TRH. Both the dopamine D2 receptor and the TRH receptor are expressed in the equine pars intermedia. Now, because PPID is a neurodegenerative condition that results in a loss of dopaminergic inhibition of the pars intermedia, this leads to an overproduction of what's known as pro-opiomelanocortin-derived peptides, which include hormones like ACTH, alpha-MSH, beta-endorphin, and CLIP. It is thought that perhaps one or even several of these hormones might be involved in the development of the clinical signs associated with the disease. So when it comes to diagnosing PPID, I'm sure we're all familiar with using the baseline ACTH sample. However, the TRH stimulation test, or the thyrotropin-releasing hormone stimulation test, has recently become available in Australia, which is really exciting for us vets because it allows us to diagnose PPID a lot earlier in some cases, and especially in those cases that might be missed on a baseline ACTH sample. So TRH normally stimulates the pituitary gland to release thyroid-stimulating hormone. However, in horses with PPID, TRH also causes an exaggerated release of ACTH from the pars intermedia due to pituitary hyperplasia. And it's really this exaggerated response that can be used to differentiate PPID horses from non-PPID horses. So how we use this test is really easy. You want to collect your first blood sample into a purple top or an EDTA tube. Make sure you label that with the horse's name and mark it as T0. You then immediately inject the TRH intravenously. Make sure you set your phone timer to 10 minutes. And as soon as that timer sounds off at 10 minutes, you want to collect your second blood sample into a EDTA tube and label that as T10. Now, it's really important that you take that second sample exactly 10 minutes after you've administered the TRH. There has been a study which has shown that the precise timing of the sample collection is really critical to ensure accurate assessment of the PPID status of that animal. The findings of this study showed that there was significant variability associated with even minor alterations in the timing of the sample collection. I always set my timer, so as soon as it gets to about 9 minutes, 40 seconds, I'm walking up to the horse or pony, I'm raising the jugular vein, I'm ready to go in to draw that sample. So deciding on whether or not to use a baseline ACTH or a TRH stimulation test will depend on a number of different factors. I'd consider things such as the age of the animal, any previous laboratory testing, and also what signs they're showing. If you have a young horse with maybe some milder clinical signs, I'll probably do a TRH stimulation test. On the other end of the spectrum, if you have an older horse with more advanced clinical signs, baseline ACTH is probably going to give you an accurate diagnosis. But these are sort of conversations that I have with owners, depending on which test I might do. If you run a baseline ACTH and it comes back normal and your clinical suspicion of PPID is quite high, you might need to come back for a second visit to run a TRH stimulation test. So something to be aware of, after you've administered the TRH to horses, some of them will do some odd behaviours. They'll do things like licking and chewing, they'll start yawning, some of them will cough intermittently. This should only last a few minutes and it's nothing to be concerned about, but it's always something that I'll warn owners of prior to doing the test, just so that they are aware of it. So one thing to note about performing these tests is that there's a number of different factors that can influence ACTH. I tend to not perform ACTH testing in any animals that's actively laminitic because stress and pain can falsely elevate these results. I typically will manage their laminitis with pain relief, perhaps some insulin-lowering medications like SGLT2 inhibitors, and once that is stable, I might come back in 2, maybe 4 weeks and then measure their ACTH concentrations, whether it's through a baseline ACTH or a TRH stimulation test. There's studies that have also shown that transport into a hospital for say about 20 minutes can falsely elevate ACTH levels. So it's just a matter of taking these things into consideration when you are testing these animals. It might be something that you want to consider doing at home where there's potentially less stress involved, or if they do come into your practice, maybe wait 30 minutes to an hour or so until they've settled down prior to running your ACTH test. Now, whether you're interpreting the baseline ACTH or the TRH stimulation test, it's important to take into account the seasonal variations. In horses with PPID, the plasma ACTH concentration has what's called a circannual cycle, and there is an increase in endogenous ACTH concentration leading up to and after the autumn equinox. Now, if we just focus on the TRH stim test, you can see here that in horses, regardless of the time of year, if you get a 10-minute TRH result of less than 100, PPID is unlikely. Now, during the winter, spring and even early summer months, if you have a result between 100 to 200 at 10 minutes, this falls in what's called the grey zone, like I mentioned before, or the equivocal zone. So you want to make sure that you have fairly strong clinical signs before you go ahead and treat that animal. Now, if you get a 10-minute result that's over 200, this really means that PPID is quite likely, and certainly if I got one of these results, I would feel confident to go ahead and initiate treatment. Now, the routine testing of horses, especially younger animals below the age of 15 years who may not have any clinical signs, is currently not recommended. Some vets won't do the TRH stimulation test in the autumn due to that seasonal rise. I think you can probably still do it, but you just want to make sure that you interpret the results very, very carefully. Me personally, I tend to not do the TRH stim in autumn, and instead I'll use it more in the winter months and early summer when the baseline ACTH might actually miss some early cases. One thing I did want to touch on is laminitis and PPID. There have been studies that have shown that horses with PPID that did have laminitic changes within the lamellae of their hoof actually had hyperinsulinemia. Those with PPID that didn't have laminitic changes had normal insulin concentrations. So this tells us that it's really insulin that's the driver for laminitis. PPID can exacerbate this issue. So when you're dealing with a laminitic animal who's older, you need to manage both PPID and insulin dysregulation in order to prevent any recurrent episodes of laminitis. If you just manage the insulin and ignore the PPID, or vice versa, you're more than likely going to have recurrent episodes of laminitis in that horse or pony. So there's a really nice study that came out that showed that you can combine the TRH stimulation test with the oral sugar test, and doing both of those tests together won't actually affect the results of each one. So this is really useful if you've got an animal with insulin dysregulation and PPID. You can combine both tests into the same visit, which is always really helpful for us busy ambulatory vets and also saves the owners a little bit of money. So what you would do if you're combining both of these tests is you'd perform the TRH stimulation test first. After the 10-minute sample has been taken, you then go ahead and perform your oral sugar test as normal. So there's a couple of different treatment options that we can talk about. I think everybody's familiar with using Pergolide. It's probably the one that we've been using for several decades now, and one that we've got the most clinical experience of. But there has been a study that has come out to show that owner compliance when administering once daily Pergolide is not that great. And vets often overestimate the compliance of using this once daily medication. So the extended release cabergoline formulation just gives us an option that we could potentially use in some animals that might be refractory to once daily oral medication. Now, there isn't a lot of data about using extended release cabergoline. We published a study a year or two ago now looking at clinical cases that have been treated with cabergoline. And the dosing that I typically use now in the majority of cases is 0.005 mg per kg, once weekly or once fortnightly. However, there are some animals that will display some typical side effects when using dopamine agonists, and this can be things like lethargy, inappetence, drowsiness. So some of the things that you might want to consider doing if you're using cabergoline is, rather than start at that 0.005 mg per kg dose, you might want to start at a half dose of that. So I would typically use 0.002 mg per kg when I'm starting using cabergoline. And this just allows you to just see what that animal is going to do on a lower dose. You can also then check their levels after using a lower dose, and some horses might be fine to stay on this 0.002 mg per kg dose, but you can then titrate upwards if you need to. Just remember that if they do show any of these side effects when they're getting cabergoline, it's not like when they're getting the once daily tablet of pergolide where you can just stop the dose for a few days and then restart it on a lower dose. If you're using cabergoline, once you've given it to the animal, you can't take it back out. So you do need to write out the duration of signs, and some animals will have these side effects that can last up to 5 to 7 days. Those aren't common, but it's certainly something that you should be aware of. This is why I think that starting at a much lower dose just allows you to see which of these animals are going to show those signs and hopefully mitigate some of these side effects. So just to round things up, I just want to mention a case of mine. This is Calvin. He's a 19-year-old Andalusian gelding. He's had a history of recurrent episodes of laminitis that we struggle to manage based on diet and management changes alone. So given his age and history of recurrent episodes of laminitis, we decided to run a TRH stimulation test just to see if PPID might be contributing to these previous episodes of laminitis. And you can see here that his baseline ACTH was 45, which would be considered normal for this time of year in Western Australia. However, his 10-minute ACTH result was over 1,250. We went ahead and initiated treatment with extended release cabergoline because the owner was not able to medicate him once daily with pergolide. And approximately 30 days later, I repeated the TRH stimulation test on him. You can see here there's not much of a change on his baseline T0 result, but his T10, so his 10-minute ACTH concentration, had reduced significantly to 289. It's important to note that even though you might initiate treatment, not all horses will have their ACTH return to within the normal seasonal reference intervals. However, when you are managing these cases, it's important to look at the overall clinical picture. So Calvin hasn't had any recurrent episodes of laminitis. He's doing well. He's been able to maintain his body condition, and we've taken that as a sign that his PPID is under control.